A lot of times in medicine, I feel like we are the frog that have been in the water that has been getting hotter and hotter and hotter. And something that is a great example of this is supply chain shortages. So when I started off in medicine, which I was just reminded of recently that I've now been practicing for 10 years since residency, it was pretty uncommon to have a supply chain issue affect us. And now it's more common that I'm getting an email telling me that a drug or something that I thought was always something we would have is something we may not have. And many of the listeners can probably remember recently that there was a supply chain shortage related to saline. So we were actually rationing saline in many of the emergency departments that I worked in. And so that's why when I got a message that Tony Paquin was interested in coming on this podcast, I jumped at the opportunity because Tony Paquin is a pioneering entrepreneur and healthcare innovator with more than 30 years of experience transforming the industry. He's co-founder and CEO of iRemedy Healthcare. He's championed the integration of retail strategies and advanced technology to improve patient engagement, streamline systems, and strengthen the medical supply chain. And he's wrote this amazing book, The End of Us, that dives into the issues that are really putting our supply chain and medical supplies at risk. So, Tony, it's great to have you on the podcast.
Thank you, Andrea. It's great to be here. I appreciate your taking some time with me today.
Yeah, so let's hear a little bit more of your story. I don't think most of us probably, when we were deciding what to do with our lives, would have woke up and said, I'm going to be involved in medical supply chains. So, how did you become a change maker in this realm?
Yeah, it's funny. I tell my kids that same thing. They go off to college, and I try and remind them whatever it is you're going to college for is probably not what you're going to be doing 20 years from now. So don't get too hung up on that decision. My background, and really many of my business partners, is technology. We're actually software people. And we were in the insurance industry. I did a very large software company in the insurance industry. And my second software company was an electronic medical record, web-based software deal. And then that led me to begin working with hospitals. And that's when I wrote another book called The Retail Healthcare Revolution. And we're focused on retail strategies, which is a very interesting area, I think, for you and for a lot of your healthcare providers. We're working with hospitals. In that process, we started dealing with supply chain because we were building pharmacies and we had to buy drugs. And so I'm a technology guy. And, technologists, I think by definition, are disruptors. Like we're always looking for a better way. Change is the one constant in the software industry that's constantly reinventing itself. And today, of course, faster and more furious than ever, given the AI revolution. But it's the normal thing for us. So we're not married to the status quo in the software business. You're constantly thinking about how do I do something better? How do I change it? How do I modernize it? Something like that. So we were buying product for pharmacies and hospitals, real high volume, and dealing with the traditional big suppliers, McKesson, Medline, Cardinal. We used to be called ABC, as now it's Concora, GPOs, PVMs, all these different organizations. And frankly, very old system, full of all kinds of layers and complexity that just very expensive and very difficult to operate. And so we thought, oh, gee, we could invent some software and improve this. That's how it all started. And that naively, because things always turn out to be more complicated than you think.
Yeah.
You mentioned the saline thing. I think it's actually a really good example, though, of what's going on in the world today. So a couple of really interesting observations. One is the FDA tracks drug shortages. So there's like a list of products that are in shortage at any given time. Today, there's more drugs in shortage than at any time in the country's history, which is For somebody not in the business, it's surprising. Like, why would that be?
But it's very true, right? I mean, we're
Yeah,
allegedly a first world country, right? That's what I keep saying.
exactly.
And when I go to work, I'm like, I do work in America, right? And I'll ask really common drug like benzodiazepine. I was ordering Ativan and somebody's like, oh, that's on shortage. And I'm like, how is Ativan? Lorazepam is the generic. I don't want to give any company names, but how is that on shortage?
Exactly. I mean, you look at this iPhone, right? That's
Hmm.
not on
Yeah.
shortage. We can go buy all that we need to buy. It's a very complicated thing. Why is that not on shortage, but the drugs are on shortage? And there's reasons, obviously, why, but here's part of what it comes down to. One is that it's globalized. That's problem number
Yeah.
one. Now, your saline is one of the best examples of that. The really interesting thing about saline, there's a little bit of saline manufactured by Baxter here in the United States, but most saline is not that we use every day, all day. And mostly it's made in Puerto Rico. And that works out fine until it doesn't work. And there's a hurricane that blows through Puerto Rico and knocks their power out. And then we're done. We have no saline at that point. We'll be out of saline like, in a week or two. There is nothing to get. And it's water, basically, right? It's really, really, really clean water with some things added to it. But that's basically the saline solutions. So when you think about it, Coca-Cola doesn't ship in Coca-Cola from China. They might ship in the syrup, but they mix it with water in the local communities where they distribute. I mean,
Mm.
even if you buy a can of Coke in LA, that wasn't made in Atlanta. The syrup may have been made in Atlanta. It was shipped to California. It was mixed with water and bottled. Yeah, saline you think would be similar, but it's not. It's another example of the industry evolves into this sort of single source solution for products. And then that works, as we say, until it stops working, that doesn't work at all. We obviously saw this in COVID in a very big way. And my firm was one of the largest COVID, we were one of the largest vendors in Operation Warp Speed. We imported 1.4 billion items in order to meet the requirements of the federal government. And it really drove home our dependency on a very fragile supply chain. And in the healthcare provider world, hospitals, physicians, medical practices, surgery centers, and so forth, they're largely separated from the problem, like as you described, right? You're a physician, you go to work, you expect the drug to be available, you really don't know the details at all. And what's actually happening is that drug supply chain is very precarious. It's easily broken. 80% of all drugs in the United States track back to China in one form or another, either raw material or finished goods. India is the other big provider. And you get a war in Iran or you get a hurricane in Puerto Rico, and you're going to disrupt that global supply chain. And we don't have reserves on hand. United States, we carry maybe 30 days of drugs stocked domestically. It varies by drug, but for the most part, the system was designed in that sort of just-in-time inventory concept. And that works until something breaks on the manufacturing side, then you run out. So it's a real problem. There's no question about it. There's two big problems that I think providers should be aware of. One is that sort of frailty of the supply chain. The other is the quality. Yeah, the quality is the other one that I think surprises people. And so in the United States, like I work with a really good company called Oxford Pharmaceutical. They're a manufacturer of generic drugs in Birmingham, Alabama. And you go on their facility, it's state of the art, it's modern, it's very clean, it's what you would expect it to be. Okay. And they'll have a room where they make a drug, mixing machine and all this stuff. The powder comes down and they make the drug and little pills come out and all that. And when they're done, with that, now they're going to go, okay, we've made whatever, 5 million of these pills. Now we're going to make a different drug. And they empty the machine out and they deep clean it, right? To prepare for the new drug that's coming in. Now they'll actually take like a cloth type thing and they'll swipe the wall and then they'll run that through a testing machine to see if there's any remnants of like dust or anything, that's on that wall,
Wow.
that previous drug. And they'll even do it on the ceiling. They might be up there like 15, 20 feet, but they'll take a sample off that ceiling and they'll test it to make sure it's perfectly clean. And the FDA may inspect them, surprise inspection, and the FDA may do the same thing. That's USA. Okay, but our drugs aren't made in the USA. They're made in India or China. And in India, they don't have the FDA, right? They got this local group and that local group. I don't know if you know India at all, but India, I get in a way like the United States, is a compilation of states, right? But they're very different. Like they speak different languages, they have separate governments, they have separate regulatory environments. So when you move around India, you're really kind of moving around different countries, but their oversight isn't even near the oversight of the United States. So we have lots of drug contamination, wrong pills, wrong drugs in the pills. You can inspect a facility and there'll be a hole in the roof. I mean, talking about swiping the walls, you got rain coming into the building. You'll have raw materials stored outside in the parking lot. Like it's a whole other world. And there's been studies done where a drug comes in from India and a patient is taking that drug and then they're monitoring the efficacy. And if they know that the efficacy of that drug is worse. Because there's a lot of science involved in like the dissolved rate, the purity, whether the chemicals are in the drug. It's a precise science to make a pill.
Just have to interrupt for just a second. So, common sense would say if a drug is being made in India and it's an FDA approved drug, we say all the time, oh, well, this is an FDA approved drug. This
Right.
is different than a supplement. Their supplements aren't regulated. But if it's an
Yeah.
FDA approved drug, you can trust that if it says it's a tablet of aspirin, it's a tablet of aspirin.
Yeah.
But are these drugs monitored? Is there a QA process for when they enter the United States?
No. So there's random testing that some organizations will do. Like the VA will test some drugs coming into the VA, but there's not a mass testing protocol. That doesn't happen. Yeah, you think about it, it'd be a lot, but it just doesn't happen. We inspect, I think the last number I read was about 28% of facilities around the world that are manufacturing in the US. And just to clarify, the FDA, when the FDA says that's aspirin in that pill,
Mm-hmm.
that's not really what they're saying. What the FDA first says is aspirin is a safe thing to take for certain purposes. That's one. And then the second thing that they're saying, maybe, for example, is Excedrin contains aspirin as part of the formulary of the Excedrin finished product. But the FDA isn't really saying we're monitoring that factory in India to make sure that they're making that drug exactly according to the specifications and using the right raw materials to make that drug. They don't have the ability to do it. We don't have the legal authority to do a surprise inspection in China. And by the way, there's no such thing as a surprise inspection in China. That's a contradiction in terms. A, they know you're there. B, artificial intelligence, they're tracking your every move. There is no such thing as a surprise inspection. It doesn't happen. It's just a different world. To your point, in America, we assume America. Like we think of the way we do things. But India is not America. They do things the way they do things. And the US Senate, I guess it was last fall, it was like last November or something, on this exact subject. And one of the ways we illustrated it was I said, the generic drug manufactured in Birmingham, Alabama, is assumed by many people to be equivalent to that generic drug manufactured in India. And that is not true. They're not necessarily the same. They're supposed to be, but they're not really. And in his Senate testimony, it was very bipartisan, by the way. It was great. It's chaired by the Senate Committee on Aging, chaired by Senator Scott, Senator Warren. Yeah, on the other side, they call her the ranking member. She'd be the Democrat senior person on the committee. And the committee was pretty unanimous in this issue. There were four of us testifying that day. And at one point, Senator Scott went through each person and said, if you were taking a drug for you or your family, and you knew that drug was from India and you could get it from an American source, would you switch? And 100% of the people who are in the business of making the drugs said absolutely positively, no question about it. As would I, no question. And so that's an issue to just be aware of. One of the things that we're focused on policy-wise is the idea of labeling. So you think about it, I could pick up anything on my desk here, and somewhere on that thing, it's going to say made in China or wherever it's made. That's because it's a law. When something is imported into this country, it must state where it was manufactured, but not drugs. So you get your little prescription bottle, you'll never see it say made in China or made in India. And so patients don't really have that input. That's the deal. When you look at all the things happening in GLP-1s and peptides, I'm a big supporter of the peptide market, for example. I think there's massive potential clinical value there. But just know that's all made in China. I don't think there's a single domestic manufacturer currently of any peptides or GLP-1s. There might be, but I don't believe so. Not of significance, there isn't. Once again, you're having these huge things take place, right? Like, I don't know what percentage of Americans are on a semaglutide or tirzepatide or Ozempic or Wegovy, but I don't think any of those products are made in America. So, yeah, 30% of the population probably using a drug made somewhere else. And now the very large companies, when you're talking about like an Eli Lilly or something, yeah, they have their corporate standards and they're going to do a reasonably good job of maintaining standards. But even they, in many cases, have to rely upon the supply chain, in other words, raw materials. So a complicated problem.
Yeah, I think you've succeeded in making a lot of us feel very anxious about this. What can the average person do? What can the average healthcare professional do about this problem?
Yeah. Well, first, I would say overall, okay, that, everything I described is very real and is of great concern. However, I would also say that I am an optimist when it comes to healthcare and the era that we live in, right? So artificial intelligence, as an example, is going to have a very positive impact on healthcare in many different ways, not just clinically, but operationally, like in this area of supply chain management. A lot of what we deal with in my business is we're a logistics company. So other things we do in the supply chain is like the innovation around medical devices, or there's people inventing things, and a lot of innovation happening right now in the healthcare world, fueled by entrepreneurs. By the way, many, if not most, are healthcare providers. They're physicians, nurses, people who somehow worked in the business and said, hey, there's a better way. And then they invented something. That market, which I've been involved with for a long time, is so active right now. It's amazing. And so I think There's lots of reasons to be very, very, very optimistic. When it comes to drugs, I think it is important to be first is to be aware of that first problem, which is the availability, scarcity, risk factor. And one of the things that surprises us in that area is the failure by people overall to be thinking about equivalents or substitutions or being ready for it. You can do like this graph analysis. Like currently today, I look on one of my systems because we track it here, but I think it's around 325 shortages or 340, something like that, are currently active. But those 340 products have been in shortage 10,000 times. Could see if you did that math, there's probably like an 80-20 rule where 20% of them are probably in shortage a lot, like hundreds of times. So there's a propensity for some of these products to be in shortage. And you just want to have an awareness around that. I mean, I think it's important. It's part of healthcare. Yeah, it's not a good part of healthcare, but it is part of healthcare. Like we should know our drugs and we should know what the availability is. That's one. Two is resist strongly single source solution. So the healthcare industry, starting about 20 years ago, for all kinds of reasons, depends on how much of a conspiracist you are, they kind of morphed into the direction of single source thinking, right? So your hospital probably has a primary contract with one major vendor. And literally a contract says that they must buy 90% of their supplies or their drugs or whatever the case might be from that vendor. The vendors say that because they're going, and we're going to build a warehouse for you. We're going to manage your supply. They're saying they're selling them a reason as to why they're going to do that. But that makes you vulnerable then to that vendor's supply chain. And it gets very, very complicated because what happens is I make a drug, right? And I'm saying I'm going to give 20% of my production to McKesson. That's allocation. You'll hear the terms allocation. And McKesson will go to your hospital where that is. They're going to go, we're going to allocate you 10,000 doses a year because based on your previous history, that's what you use. Well, then your hospital buys another hospital, okay, or a couple of clinics. Like their usage changes. So going against last year's usage screws up this whole allocation logic. And then that's happening just all over the place. So when a drug isn't available, it's not really saying the drug's not available. It's saying the drug's not available to you from that vendor. And what healthcare providers should be doing more of, and it's difficult because the vendors discourage it. But what'll happen is you have a product, as you described earlier today, and it goes into shortage. And then if that was in the hospital, then the pharmacist in the hospital, the inside pharmacist going, oh my God, we got this shortage. And they're going to work it. They're going to call their drug supplier, their distributor, but then they may start calling alternative suppliers to try and solve the problem. But those alternative suppliers, they're not really in your camp. Like you don't call me till you got a problem type of thing. If you were making cars at Ford Motor Company, you would not have one supplier for steel. Like it's a known thing in business. In business, you do not become single source dependent. That would be evaluated as a risk. There'd be a risk manager who'd go, oh, we're at risk. Just like you don't concentrate all your business with one customer, you don't concentrate all your business with one vendor. Most large businesses would never do that. Hospitals, on the other hand, have concentrated like 90% of their supply with one vendor. So even if you have like a small practice, you run a clinic, a practice, a surgery center, Medline or McKesson's going to go in there and they're going to go, yeah, we want all your business. We're going to give you great prices, but you got to buy everything from us. Now, I would resist that whenever possible. I would make sure that I'm developing a diverse supply chain. That's just common sense thinking. But I would say the vast majority of healthcare really doesn't think that way. So think about multiple sources. Then going to the quality issue, really look at the quality discussion, encourage patients to be informed, encourage pharmacists, maybe inside your system or your organization, to be informed. Is that product coming from India? Is that product coming from China? How reliable is that supply chain? Yeah, it's a real thing. Like, you have to be informed. That's what it comes down to.
I'm curious. So when you need a medication, or hypothetically, if you were hospitalized or if a loved one has been, like, are these questions you ask? Like, how do you even find out?
The first answer is yes. Now in the hospital, yeah, nobody knows. Like, you could ask the nurse, sure, heck doesn't want to know. They don't really want to be bothered by the question, because what are they going to do? They don't have access to that information. And if I were a clinician inside a hospital, I would bring up the quality sourcing issue and encourage that system to be more informed. When we did this work with the government, everybody was shocked, but everybody in the business knew it to be true. But at the pharmacy, like the retail pharmacy level, I absolutely would be looking at a product. Now, I'm in the business, I know. But I wouldn't hesitate saying to a pharmacist, do you know where this product came from? Like, I would know that. I would 100% ask that question. Yep. Yeah, and that's where maybe the good old independent pharmacist has got a little bit of an advantage versus the Walgreens or the Rite Aid. That Walgreens pharmacist doesn't know. He's just a corporate employee. But that independent guy might be more aware. He's a little more thoughtful, frankly.
Yeah, that is so fascinating. And for the listeners out there, it's actually kind of well known that of the committees in the hospital, one of the most powerful is the Pharmacy and Therapeutics Committee. And it's not like real sexy, like, oh, I'm on the Pharmacy and Therapeutics Committee. But I think anyone out listening, if you are on that committee or you interact with somebody who is, this is something that you should bring up. It seems like a new business item is like, hey, where do we get our drugs from? How do we have any redundancy in our supply chain? And have we looked at the quality? And it kind of breaks my heart, because you think about some of these patients that are like right on the line
Yep.
between their CHF is so bad. And if the difference between their diuretic being 100% effective versus 90% effective might be the difference between a hospitalization and not getting hospitalized.
That's exactly right. And the other thing is, think about it. Well, first off, your one comment about the power of the committee is very true. And just to give you a sense, in many mid-sized hospitals, think of it like a secondary market hospital, but large. Let's say they're doing $3 or $4 billion a year of revenue. Most of the profit of that hospital, now I understand most hospitals are not profit, but they still have to operate with a positive margin in order to stay in business. They just don't pay taxes on it. But they still have to operate not at a loss, so they're attempting to do so. But the financial viability of that hospital is almost entirely dependent upon drugs. It might be the 340B program. It might be the retail pharmacy. It could be home infusion. It could be a lot of different things. But drugs is a very big part of the business. I hate to talk about the business side, but I'm just saying, yeah, it's very, very important. Now, what I think is interesting about what your comment is, I think a way to think of it is, think about in the treatment of patients, you've got the clinicians, the physician, and others who are taking care of that patient, providing care to that patient. And behind them is, in the case of drugs, the supply chain. Now, you're aware of the risk to the patient when the supply chain fails either in quality or availability, right? But how well coordinated is that conversation with the supply chain people? Like, for example, if you have a drug, let's say, your formulary. So let's say in the hospital, we use these 2,000 drugs. Okay. Well, a certain analysis could tell you, well, these 32 drugs are the ones that are likely to be in shortage. Well, you would probably say, well, gosh, these four are really important. If we ever run out of these, we can have a patient die. This is really serious.
Right.
Why don't we buy an extra 20 of them and keep them on hand? There's a whole thing about aging, but there's ways to manage that properly. So
Right.
hospitals wouldn't want to say, well, let's buy 6 months of everything and put it in inventory. Now, they don't want to do that for all kinds of obvious reasons, right? There is good logic that says, what's our high risk products combined with high risk patient? Maybe we should keep 90 days on hand or 100 or 6 months on hand. And therefore, when they go into shortage, we still got product and then we got time to go solve the problem.
Right.
It's like, the one that I was going on now, what's it called? The patch for women who are starting to do hormone replacement therapy. And that's 44 days in shortage right now. That's been unavailable for 44 days. And the government changed the ruling on that treatment to make it more allowable. So demand has gone way up. And that's an example going back to my allocation thing. How many units are available today was a decision made like a year ago. So if anything changed in the marketplace, the system hasn't caught up yet. So
Yeah.
these are all things to consider, but I would really encourage clinicians, physicians specifically, to think about, well, in my world, whether it's cancer care, by the way, a lot of shortage on cancer drugs, a lot of shortage on youth cancer drugs, which is horrible and shocking. On the one hand, I do chemo work, but on the other hand, I do weight loss with GLP-1s. Whatever the case is, what are the drugs I use? And how does my team that supplies those drugs, how are we communicating? And am I revealing to them either high risk concerns I have about patients, like it'd be very, very, very important that we're always able to do X, Y, and Z, or am I anticipating a huge change in demand based on something happening? Giving my team advance notice to prepare for that change in demand.
Yeah. One last question before we start the wrap up. I had heard a plan for a while that the state of California was going to start to make its own insulin. And part of the thought process on that was insulin is so expensive and there were so many people on state subsidized programs or Medicaid that they were just going to do it themselves. Is that part of the solution when you're talking to lawmakers about trying to strengthen the supply chain, is bringing some of this back in? Is that even on the possibility list?
Well, yes and no, but talking about the California thing for a minute. So first off, even at my company, and a big part of what we were talking about in the Senate hearing, and many people in government, I know Rick Scott in Florida, I'm sure Elizabeth Warren's on the same place coming out of California, but Senator Scott is huge on the conversation, domestication of the medical supply chain. And there are a number of companies who are already building manufacturing facilities and bringing it back home. There's a lot of really great reasons why to do that. As far as, I'll go into those in a moment, but as far as the insulin in California thing, they also tried to build a high-speed rail, and they're having trouble with that. I'm not really a believer in the government making things, but I do think the idea of making insulin in California is a great idea. But I think we should have the insulin makers do that. And we could incentivize them. We could do public-private partnerships. I mean, there's a very important role for government to do that. but I'm not so sure the government should build a manufacturing facility. There are people who are very good at that, and it is complicated. But there's huge advantages to making it in the United States. One is the quality issues could be far superior because you're here, you can inspect it with the FDA. The reliability thing is far superior because you can amp up production. The other thing is the logistics. You're not shipping it. The drug you're using today, it was probably made 2,000 miles inland in China. They put out some trucks. It drives across the country. It sits in a warehouse for a while. It gets put on a container ship. It moseys its way across the Pacific, burning all kinds of carbon fuel, by the way, as it does that. And then lands somewhere over here in the Americas, gets put on another truck. It ends up at UPS Healthcare in Louisville, Kentucky, where from there it moves into McKesson facilities and eventually a month or two later, literally, get to your hospital. It takes about 4 to 6 months to move a product from a factory in China to a doctor's office. When Oxford Pharmaceutical makes their drugs in Birmingham, they can have them to the day after tomorrow. Like it's America. We put them on a truck, we drive them across the country. It's pretty simple. And that's that huge advantage because the notion that it's cheaper to build something in China, certainly there's a lot of truth to this, and they use slave labor and a lot of things over there. But it's offset by the huge costs of moving it around the world and all the middlemen that's involved. Because as I described, when it's moving those 6 months, it's owned by several different companies. There's a lot of buying and selling taking place before it ever gets to you. And if you had the supply chain here, you would operate way more efficiently and reliably. Yes, it was true in the 70s, in the 80s, maybe into the 90s, it was super cheap to move to first Japan and then China, mainly because of labor costs. But today, frankly, things are so automated. It's robotics and technology that it doesn't take that many people. And so you can have a manufacturing facility in the United States, still employ a lot of people, quality jobs, but you can do it cost competitively, is the point. A huge part of the solution is to move the supply chain back. And that is very likely to happen, but it's also going to take 10 years time frame.
Yeah. Well, this has been such an eye-opening interview for me. And we love to leave the audience with a few leadership pearls. So what's your top tip for change making?
Again, I think that I embrace the innovation that's happening today. I'm a huge proponent in artificial intelligence. We haven't talked much about that, but I believe that those things are all good and positive. They're going to impact the drug business, but they're going to impact all parts of the business. I would absolutely embrace those changes as they're occurring. I think there's tremendously positive things happening in the drug and device world, and I would optimistically look to those things. What I would propose when you think about if I were a physician and how could I be a change agent, I would make that connectivity between the service I render and the products that I use. And really think about those products, whether it's a medical device or a drug or a sleep apnea test or whatever the case might be, as part of my treatment. And therefore, how can I engage with that and really do a better job of not just giving care and advice and guidance to a patient or a care team, but also having an educated awareness of what products are involved in this patient. How can I know more about those products and therefore deliver better care because those products are part of the care plan? And so I would be thinking about innovating how I'm using products, how I'm integrating them into the care plan, my awareness of them, my managing sort of upstream into that supply chain to provide better care. If you're a physician leading a team in a hospital, you'd want to train those nurses who are helping to provide care. Well, likewise, you want to think the other direction and train the supply chain people who are helping to really provide that care. Think of them as the form of a caregiver.
Yeah, I think listening to this, the analogy is a lot of us want to know where our food comes from now, right? We talk about buying local. And so I've never really thought about this when it comes to medical supplies or medications. Now, I'll use an example for myself. The supplements I use are from a company called Designs for Health. I actually know the rep that I buy my supplements from, and they have a factory in California. She's been there and knows their QA processes. So I'm comfortable getting them because, I have that personal relationship. So
Yep.
I think that really gives us a lot to think about. And it just goes to show how complicated healthcare is.
Mm.
But I think this was great. I learned a lot. So tell us again the name of your book, how listeners can get it, and if you're available to speak with healthcare organizations or how people could connect with you.
Absolutely. I'd love to do that. The book, by the way, it's on Amazon. It's called The End of Us. The subtitle is A Story of Death and Deception and China's Deadly Grip on U.S. Healthcare. It's a story about we were hired by the U.S. government to bring in needles and syringes for the vaccination program. And all the other vendors who were also hired failed. We were the last man standing, so to speak. And we ended up moving about 1.5 billion items and chartered in the end 140 jets, a huge airlift to get it done. But in the book, we describe, first off, it was like a war story. We had the Saudis showing up with SUVs full of gold bullion, trying to bribe our loading dock people. And we had people impersonating us, trying to steal our inventory. The Chinese Communist Party at one point took 40% of everything we had in the country, and on and on and on. And so it's a fascinating story. It reads like a Tom Clancy novel. It's all true. But in it, though, what we use that story to describe using these real facts, how the supply chain works. So we had to get raw material, and then we had to get the factories, and then we had to get tooling for the factories, and then we had to get the logistics. And it shows you, it helps you really understand how healthcare products move around the world. It sounds like a boring topic, but it was a wild time. And it's interesting and I think informative. So that's on Amazon. I'm pretty active on X, formerly known as Twitter. So people can see me there where I talk a lot about these exact issues. And then our company name is iRemedy, IREMEDY, iRemedy.com. And yeah, we're very accessible. And we do meet with healthcare systems, offices, surgery centers, all the above. We're very active.
That's great. I just want to thank you for what you're doing. I think you exemplify one of the unsung heroes in healthcare. You're behind the scenes, but if you weren't doing that work, our patients couldn't get the medications or the supplies they need. So I've learned a lot, and I'm excited for our listeners to hear this, and certainly a great reminder of one of the main focuses of this podcast is advocacy. So what I'm taking away from this episode is we need to advocate. And because anytime Dr. Wendy Dean wrote a wonderful book called If I Betray These Words, and the point that she makes in that book is at any point, one of us can need the system. Doctors aren't immune from this. Nurses, pharmacists, none of us are immune from this. At any point, we might get that cancer diagnosis and need that chemotherapy. So all you fellow change makers out there, let's keep talking about this. And we all have advocacy portfolios. Many of us go to the State House or Capitol Hill, and this is an issue we need to continue to advocate for. So Tony, thanks for being part of the change maker community with us.
Thank you, Andrea. I appreciate you and everything that you're doing. I think you're on a great mission. So just continue on.
Thanks.